We started working with Anca back in 1987 when we saw a first paper out of Holland, and it's kind of been the focus of what I've done mostly ever since then. Anyway, at the time, Anca was mostly associated with Wegener's, and Wegener's, of course, has been changed to granulomatosis with polyangiitis, but subsequently it was associated with this kind of entire spectrum of clinical syndromes, all of which have certain overlapping kidney features. When I look at the differential diagnosis of pulmonary and renal vasculitis, I think of 4 categories of disease based on how the antibodies deposit in the kidney. And of course, with the Anca, we're talking about pauci-immune, and I should say relative absence of immunoglobulin deposition. There certainly can be some, and there's some occasional cases that have moderate or even little more than moderate, but they're never, almost never high-grade immune complexes like you might see with lupus. So the spectrum of vasculitis includes granulomatosis with polyangiitis, the new name for Wegener's, microscopic polyangiitis, which includes the syndrome of alveolar hemorrhage and nephritis in many cases. There's renal limited variants, Churg-Strauss syndrome, or eosinophilic granulomatosis with polyangiitis. I want to mention to every group that there's a strong tendency among patients with MPO Anca to have pulmonary fibrosis, and the pulmonary fibrosis is often misleading, but you have to think of that as part of the spectrum. And then subglottic tracheal stenosis is another kind of unique presenting feature. And all of these, when they have renal involvement, are all associated with pretty much the same renal lesion, which is that of necrotizing and crescentic glomerulonephritis with scant or relatively few immune complexes. And when I talk about Anca, I'm only talking about 2 specific types of Anca that have been shown to be of diagnostic value. In the literature, there's a variety of others that get some press, but there's only 2 that have been shown to have any diagnostic value, and those are the anti-PR3 Anca, proteinase 3, and anti-myeloid peroxidase. I like starting by focusing on this initial phase of disease, and even in the most up-to-date kind of long-term group that's been looked at over the last 10 years or so, or more, a little more than that, there's this early mortality rate of almost 10% in almost every series. And some people go, why do they die? Why don't you treat them so they survive? But if they come in with things like this is a woman who went to her primary care doctor, and they did a chest x-ray, and she went home, but then they had her come back to the ICU. In our retrospective series, when we looked at patients with Anca out of a serum bank, those that had pulmonary hemorrhage had much worse prognosis. Without pulmonary hemorrhage, there was approximately still a 10% mortality rate up front, but patients with pulmonary hemorrhage together with Anca, historically there was a 50% mortality rate within the first few months. So this is a dramatic disease. In Norway, they collected a lot of statistics, and they divided their patients with Anca into those that had GFRs less than 15 at presentation versus greater than 15 at presentation. And the mortality rate in the group with less than 15 was almost 30% in the first year. So again, we think of Anca-associated vasculitis as being a medical emergency, and with that we've come up with 3 keys to the successful treatment of Anca-associated vasculitis. 1 is to start treatment early, 2 is to start treatment early, and 3 is to start treatment early. The key is to make the diagnosis and get started on some treatment. And in emergency situations, you even have to start treatment before you have a diagnosis. You want to start it before there's destructive ENT lesions, before there's destructive kidney disease and end-stage kidney disease, and before they have massive alveolar hemorrhage and die. The problem is that early treatment is dependent on recognition of clinical features, Anca testing, tissue histology, and I like to give kind of just, here's the spectrum again. Here, I'd like to give just a really rapid flavor of this disease, and we don't see these extreme forms so much anymore because we try to catch it long before they have these, from sunken nose, orbital pseudotumors, scleritis, peripheral ulcerative keratitis, palpable purpura, non-healing skin ulcers, lung nodules, cavitary lung nodules. This person was kind of planning his funeral when they thought he had widely metastatic lung cancer, but got much better and is doing better now. And one of the most deadly parts of this disease, though, is alveolar hemorrhage. And this is a patient that I saw as a fellow and had a clear chest x-ray the night before with a creatinine of 2 and red cell CAS, and had this hemoptysis overnight with this pulmonary infiltrate. Pulmonary fibrosis is a feature of more smoldering disease, and it can be very dramatic. Histologically, in the lungs, we're talking about this palisading of histiocytes with patches of necrosis. Arteries can be fibrinoid necrosis. The alveoli can show this, what's called pulmonary capillaritis. And again, palisading of histiocytes with giant cells in this case. In the urine, we see red cell cast, white cell cast. This is an eosinophil cast, necrotizing and crescentic glomerulonephritis, necrosis, crescents, and fibrinoid crescent. The problem is early features are very nonspecific. Malaise, myalgia, arthralgia, cough, rhinitis. Who hasn't had that? Hemoptysis and shortness of breath may be the first kind of specific clinical feature, but microscopic hematuria is often the first clue, and it always hurts me when I see the microscopic hematuria ignored for a period of time, only to have the creatinine go up to 3 or 4 before someone pays attention to it. 2 types of ANCA, the antiproteinase 3 and the anti-myeloperoxidase. The PR3 ANCA creates this immunofluorescence pattern called C-ANCA, and the antibodies to myeloperoxidase produce an immunofluorescence pattern called P-ANCA. There are 5 studies, and there's not been a new one in a long time and probably never will be, where they used the gold standard of tissue histology and looked at the sensitivity and specificity of ANCA, and the specificity proved to be very high, extremely high in all the studies, and the sensitivity was very high in the 2 renal studies and somewhat lower from a rheumatologic perspective. So the diagnostic value of ANCA, the sensitivity of the MPO was 31% in this group of 5 studies, and of proteinase 3 was 53%. Neither test was very sensitive by itself, but patients only have one or the other of these 2 types of ANCA, and the combined sensitivity was 84%, combined specificity 98.6%, and the predictive value is therefore very high in appropriate clinical settings. Furthermore, the sensitivity is higher in patients with renal involvement, and the specificity is higher when the ANCA titer is high titer. So there's lots of clues that can lead one to make a rapid diagnosis. I wanted to turn to the pathophysiology of this disease for a few minutes, and the question has come up, are the ANCA themselves pathogenic? And the origin of the theory originally came from clinical associations where the very high diagnostic value. There have been in vitro studies that shows that the ANCA can activate primed neutrophils, and this can be mediated through Fc gamma receptors, and the supernatants can then activate the complement pathway and the phosphoinositol 3 kinase pathway. But then in 2002, we came up with a model, an animal model, and people had been trying to get one for about 15 years without success. But in North Carolina, they took an MPO knockout mouse and immunized it with cloned mouse myeloperoxidase. So now you have high titers, high levels of mouse anti-mouse myeloperoxidase. They harvested the serum and the spleens and transferred it to other strains of mice. Initially, it was a B-cell deficient mice. And when the splenocytes were infused, they got this severe pulmonary hemorrhage and necrotizing eccentric glomerulonephritis. And so it closely mimicked the human condition. The serum gave a similar pattern, although it's very hard to transfuse mouse serum. I don't know if anyone else has tried it, but it's not an easy task. Anyway, so the animal model solidified the theory that there's a pathophysiologic role for the ANCA itself. So how does this all work pathophysiologically? There's some trigger, and mostly they're unknown, that stimulates ANCA-specific circulating B cells to become plasma cells that produce circulating Anca, which then binds to prime neutrophils and monocytes, activates them via Fc receptors and other surface binding, leading to the release of complement activators, proteases, oxygen radicals, causing tissue destruction, more complement activation, and amplification of inflammation. So the complement part of it has become delineated much better with this animal model, and it turns out that it's the alternative pathway that leads to the complement activation, and the classical pathway is not involved, which was kind of a surprise. But it's the inflammation that initiates that leads to the alternative pathway activation. So therapeutic approaches, how can we treat this? And I have to add that much of this, or parts of this, apply to multiple autoimmune, antibody-mediated autoimmune diseases, including membranous nephritis, myasthenia gravis, pemphigus, and even, I think, lupus responds very well to these same kind of ideas. So, and many others. So how can we intervene on this pathway? Well, first question is, how can we eliminate triggers that might be causing this? And unfortunately, for the most part, triggers are unknown, but certain drugs have been implicated, and hydralazine being the most common, but also propylthiouracil, minocycline, and cocaine levamisole, and possibly allopurinol. Secondly, there's been some demographic data that shows that silicon exposure in stone workers or miners have a slightly higher rate of this. But looking at the drug-induced cases, we looked at 2,246 patients with Anca that had come through our lab and identified 248 that were associated with the suspect drug. And how did this play out? Well, among the patients with hydralazine, there were 67, propylthiouracil 53, cocaine is associated 50, and minocycline 20. So 190 patients had one of these 4 drugs. And the astounding feature is that all of them, or almost all of them, had myeloperoxidase antibodies or myeloperoxidase antibodies with proteinase 3 antibodies, and almost none of them had PR3 antibodies alone. And when you add that all up, 96% had either myeloperoxidase or myeloperoxidase plus PR3, and only 3% had PR3 alone. And if you look at the remaining cohort, there's essentially none, or almost none, that have 0.5%, almost none that have both PR3 and MPO. So this finding of double positives of these two kinds of Anca is almost exclusively related to the association with one of those 4 drugs. And astoundingly, again, there was almost no PR3 alone in this group. So that led us to strongly suspect that the drugs themselves were responsible. A second feature was the titers. And the titers in association with hydralazine for myeloperoxidase tended to be extremely high. They were high with PTU and extremely high again with the cocaine-induced or associated. And less so with minocycline. So these high ratios of high titers of anti-myeloperoxidase again pointed to something different with these cases associated with these drugs. Age distribution among the drug-associated cases was much as you'd suspect. Hydralazine tended to be in patients that were on it for heart failure or severe hypertension in the elderly. Cocaine levamisole was in the prime cocaine age group in our country around the 40s and 50s. Minocycline tended to be younger people. The time exposure of these drugs was very long-term. With hydralazine, it averaged 2.9 years. The PTU average, or the median, was 2 years. And the cocaine levamisole, almost all of the cases we identified had been on cocaine for decades, and the levamisole appears to have been in the cocaine for the last several years. Clinical features associated with drug-induced, the hydralazine, they get pulmonary hemorrhage and acute and renal failure, RPGN. It's very dramatic, very severe often, and often leading to end-stage renal disease. The cocaine cases tend to have much less renal involvement and much more joint and skin involvement, and the propylthiouracil cases were a mixture. So the drug-induced cases have long exposures to the culprit drugs, high rates of MPO, lower rates of PR3, high MPO titers. If they're double positive, that suggests drug-induced. And it turns out they also have tend to have lots of other autoantibodies at the same time. Among the cocaine, levamisole, just something that's sparked a lot of interest in the last couple of years. They can get the crescentic glomerulonephritis. Why levamisole? Levamisole is an a deworming agent that's used in veterinary medicine. It has side effects of agranulocytosis, and it was taken off the market. It used to be used as an immunosuppression agent and an antihelminthic agent in humans, but it was taken off the market because of these side effects. Why is it present in the cocaine? It's still not completely clear to me why people would put that in the cocaine, but it is. And the cutaneous lesions can be extremely dramatic, as evidenced by some of these pictures. Cocaine or levamisole in the drug supply was very unusual in 2006, but by 2011 it was common. And then I think since then the FDA doesn't report the data anymore, but it seems to be decreasing. The incidence of these cases, hydralazine has continued to accelerate with the use of hydralazine for heart failure. PTU tends to be fading away. Cocaine was a big splash of cases that now I think is starting to fade a little bit. And minocycline, we have a smattering of cases. So hydralazine and cocaine cases have increased dramatically. Hydralazine has a very high rate of severe pulmonary hemorrhage and RPGN. Cocaine cases have a lower rate of pulmonary and renal involvement, but a higher rate of cutaneous. So we'd like to eliminate all the triggers that cause this. Altogether, that counts for a little over 10% of cases, which still leaves 90% without any idea of how to try to manage the risk. What about the circulating B cells? We can try and clear or treat circulating B cells with pulse steroids, cytotoxic agents. This is where cyclophosphamide comes in, azathioprine, and anti-B cell monoclonals. Rituximab has become widely used or widely popular among many groups now because of its success for clearing B cells. And I'll show a lot more data on that in just a minute. Plasma cells, what can we do for plasma cells? Well, we'd love to block or clear the plasma cells or plasmablasts that are making it, and pulse steroids have some effect, and particularly on plasmablasts, as does cytotoxic agents. However, rituximab has no effect on plasma cells. So it doesn't work to actually get rid of the cells making the antibodies, actively making the antibodies. What about the Anca itself? We can try and remove it with the absorption column. If someone would make one, we could try it, but so far that hasn't happened. Plasmapheresis is something that's generated a lot of interest, and in the MEPEX trial, it suggested that there was some benefit, and there's a big trial underway now called the Pexavast trial, which is ongoing and should give us some answer relatively soon as to how useful plasma exchange is. But it makes sense when you look at the pathophysiology. What about the binding to prime neutrophils and monocytes and the activation and the release of all these factors? Well, blocking priming activation, the standard treatment right now is steroids and more steroids and more steroids. Anti-TNF agents have not worked. Newer considerations include the C5a blockade, which came out of the animal model and seems to make a lot of sense as being a way to block the disease at one of the terminal ends of the pathway. C5 is involved, and C5a seems to be the factor that recruits more inflammation and keeps the process churning. So we have a small set of tools. We have steroids, we have cytotoxic agents, we have rituximab, we have plasma exchange. Perhaps IVIG could make sense, although there's no real trials of that. Other unproven agents, including the complement blockers, which are starting to be studied. So rituximab, what do we know? I think that this is kind of the big place where things are at right now. It is a very potent anti-B cell agent. It instantly clears B cells from the circulation. It has a long half-life in the circulation. The antibody half-life is approximately 3 weeks, and the half-life of B-cell depletion, or the length of B-cell depletion is in the range of 3 to 6 months or more. And here's just an example from the rheumatoid arthritis series where they looked at how long B-cell depletions last. And it basically, B-cells stay at 0 through 16 weeks and start to creep back after that, such that many patients are approaching the normal range by 1 year. So it rapidly clears B-cells, but the problem is clearance of B-cells has not correlated with clinical response. So how can that be? It didn't work in lupus, and it hasn't worked in rheumatoid arthritis. Clearance of B-cells does not lead does not correlate with immediate response or response. In the lupus trial, even with a year of B-cell depletion, eventually they saw some separation of the anti-double-stranded DNA levels, but there was in the Explorer trial, there was no benefit from the rituximab. So rituximab, the thought was that if we could get rid of the circulating B cells, the rest of this would just disappear. But in fact, the Anca doesn't go away quickly, and the plasma cells may not go away quickly, and all of this can stay behind for an extended period of time. Steroids can work on multiple different places. Pulse steroids can work on plasma cells and on circulating B cells. Continuous steroids may block some of the lower parts of this chain of events. Cyclophosphamide works on plasma cells as well as circulating B cells. So with all that thinking, how do we do induction therapy for ANCA vasculitis? Are additional treatments necessary in addition to rituximab to block or clear plasma cells, remove antibodies, block the effects of antibodies on neutrophils? And if the antibodies are not cleared with the induction regimen, will the disease kind of resurface as soon as you cut down the steroids? And there's 2 prospective randomized trials looking at rituximab for induction. One was the Rave Trial, where they used rituximab plus high-dose steroids for induction and no cyclophosphamide. And the other was the Rituxvast trial, where they used rituximab plus high-dose steroids plus a short course of cyclophosphamide. In the Rave Trial, 197 patients were randomized. The primary endpoint was remission at 6 months off steroids. So they set a high standard of being completely off steroids. And the results were that patients treated with rituximab plus their induction course of steroids, 64% achieved the primary endpoint. With cyclophosphamide and kind of a standard cyclophosphamide dosing, 55% achieved the primary endpoint. Adverse events, there was no difference between the 2 groups, and relapses we'll come back to. So the conclusion of this was that rituximab was not inferior to cyclophosphamide for induction of remission at 6 months, and in fact it almost looked enough to be called better, but it wasn't statistically good enough to warrant that classification. So what do we know? Rituximab, when used with high-dose steroids, or steroids and a short course of cyclophosphamide, clears B cells for 6 months or more, leads to falling Anca titers in both studies, appears to be as good as cyclophosphamide for the induction of remission, and appears to be no more toxic than cyclophosphamide. Well, that sounds like a win-win-win. And in fact, I think that there's a general conclusion that rituximab is part of the central role for induction of remission nowadays, except for some insurance companies have yet to buy into this. But, and more work though is still needed to define the optimum induction regimen for balancing the amount of steroids, the amount of cyclophosphamide, if any, to use with it, and when to use things like plasma exchange. And more work is needed to optimize this transition to long-term treatment. Long-term treatment becomes another major obstacle to care. You know, do we use early cyclophosphamide or some other agent? What do we use for maintenance treatment? Can rituximab be used for maintenance treatment? And what about other maintenance therapies? In terms of different induction regimens, there's a English group and there's our group have both tried a slightly different tack than what was used in the Rave Trial. And I want to show you a little bit of data that we have from that. We used a course of Rituximab, 2 doses to get started. In rheumatoid arthritis, they generally use 2 doses, not 4 doses. People have often arbitrarily gone to 1 gram times 2 doses. It's certainly easier to arrange than 4 doses. The prednisone in this trial was tapered to 15 milligrams a day by day 30, and then tapered by 2.5 milligrams per day per month, starting at 60 milligrams a day. And cyclophosphamide was added, and the purpose of the cyclophosphamide was to allow for a shorter course of high-dose prednisone and for a steroid-reduced approach. And as I said, there's an English group that's done, with Mansfield et al., that's done a very similar trial. And remission rates leading to complete remission occurred in almost every patient by 6 months, and the vast majority at around 4 months, which is when the prednisone was tapered low enough for the definition of remission. Disease activity ceased in virtually all patients except for a very tiny number of patients. And this was true whether or not they got plasma exchange, whether or not they had MPO or PR3 Anca. And so by 6 months, among survivors, 92% were in complete remission in all groups, and counting the non-survivors, 88% were in complete remission. You have to remember that this included patients who came in and were first diagnosed in the ICU after intubation and starting dialysis. So there's this, and furthermore, the age group for these patients ranges from children up through 90-year-olds. So there's a lot of comorbidity in the elderly group that makes them particularly difficult. How did the kidneys do in these patients? Interestingly, there was the average EGFR at presentation was about 23 mLs per minute with initiation of therapy. The PR3, and it turned out to be the same in both the PR3 and MPO group. Amazingly, the PR3 group improved quite a bit more dramatically than the MPO. MPO was a worse prognostic sign for kidney recovery. And that was true. If you split them into those that were sicker and received plasma exchange, they had a lower initial EGFR, and versus those that were less sick and did not receive plasma exchange had a higher initial EGFR. But still, the PR3 group in both settings, in both groups, PR3 was a better prognostic sign for renal recovery with treatment, whereas MPO had some improvement, but not as dramatic. What happened to the Anca titers with treatment? If you look at the first 4 months, this is a group of 60 patients where Anca titers, or multiple Anca titers were done and split into PR3 and MPO. They turned out to be almost identical. The MPO titers dropped by 47% per month, PR3 titers by 48% per month with this regimen. Meanwhile, the total IgG levels, which is the solid line up here, dropped by 6 milligrams, 6% per month, 6% per month. IgA dropped a little, or IgM dropped faster. IgA was very slow also. So the whole goal of this induction regimen is to try to knock out these antibodies so that they can't cause disease without affecting the total IgG levels and affecting other aspects of immunity. And it's amazing how dramatic the separation is between the pathogenic antibodies, the MPO and PR3 antibodies down here, and the IgG, total IgG, and total IgA up here. All right, so then maintenance therapy for Anca vasculitis. What do we do? Well, there's a couple of options. One, I tell patients there's 5 options, and they range from 2 extremes. One is to stop and wait for relapse and then retreat. And frankly, this is what much of the world does. Certainly at some of the meetings we've had with various European groups, this is the standard of care. The alternative is to put the patients on some kind of maintenance therapy. And how important is it to do that? What are the patient's chances of relapsing? You know, one of the early studies, and this was a study that came out in 2003, and at the time this was considered long-term treatment because they treated out to 18 months and looked at follow-up for 18 months, compared cyclophosphamide, continuous cyclophosphamide dosing through 18 months versus azathioprine dosing after 3 months, and found that both groups did about the same, but there was still a 15% relapse rate by 18 months with weaning off of weaning down and sometimes off of prednisone. So even cyclophosphamide and azathioprine with lower and lower doses of prednisone led to at least moderate relapses. Another trial tried to compare maintenance with azathioprine and MMF, and they used low-dose prednisone to start with and weaning it off. And by 4 years, even with azathioprine, there was over a 30% relapse rate, and with mycophenolate, it was over a 50% relapse rate on maintenance therapy. So with maintenance therapy, they still have very high relapse rates. In the Rave Trial, they looked at the two arms of the Rave Trial, one of which used the Rituximab by itself with a tapering off of steroids so that the patients were then on nothing after 6 months. And the other arm had cyclophosphamide together with a follow-up low-dose azathioprine, and both groups had over a 30% relapse rate within about a year after inducing remission. So very high relapse rates in multiple different studies. One more to look at, and this is from Smith and Jane, David Jane in England. They looked at relapse rates after induction with rituximab. And they found that if in patients that had previously relapsed, that approximately 80% relapsed again after rituximab within 2 years. In contrast, if they continued rituximab dosing for 2 years, they had only about 18% relapse rate. So a dramatic difference. And then if they stopped the rituximab at 2 years, these patients again started to go on to relapse. Well, with this really poor outcome and recurrent cycling of patients back on cyclophosphamide, back on Rituxan, back on steroids, we undertook a maintenance approach where we kept patients on Rituxan and kept the B cells absent for an extended period of time. And in our series, we looked at 172 patients where they were continued on rituximab maintenance. This is a non-randomized retrospective trial. And were put on continuous B cell depletion. And the dosing was 1 gram of rituximab every 4 months for up to 2 years, followed by every 6 months, and subsequently adjusting to try and keep the B cells 100% absent. Other immunosuppressive medication was weaned off completely during the maintenance, and they had to be down to just 7.5 milligrams of prednisone a day to enter. And the relapse rates for the first time showed almost no relapses. There were a very small number of what I would call minor major relapses and a few more minor relapses based on the criteria used. But only 1 patient went back on cyclophosphamide, and virtually every patient ended up off steroids for the majority of this period of time. So rituximab proved to be very effective as a maintenance agent for up to 5 or 6 years at a time. And the side effect rates were similar to the European series where they used azathioprine and prednisone maintenance with higher rates of relapse. And there were infections requiring hospitalization. There were a total of 25 in this whole group, and most of those were pulmonary infections. There was this very striking entity of late onset neutropenia. How many people have heard of late onset neutropenia with rituximab? Almost nobody. Well, I want to introduce you to this item because it's really one of the most striking complications of it, and if you have patients on long-term, you will run into it sooner or later, and I'll show you a little bit of data about it. Other complications rates were rare and not too surprising. There were 10 deaths in this group, most of which were among elderly patients and for unrelated causes. And the IgG levels during maintenance, first of all, the Anca continued to fall. Of those that still had Anca entering the maintenance phase, they continued to fall, although at a slower rate because they were on Rituximab alone at this point, whereas the IgG level fell by 0.6% per year. So it was almost no change in IgG levels during this extended period of maintenance immunosuppression with Rituximab. So that was very encouraging that there's not a lot of toxicity. Serious infections, there were 2.9 per patient year, per 10 patient years during induction in our series, which included plasma exchange patients, versus the Rave Trial, which did not include plasma exchange patients, had a 1.4% of serious adverse events per 10 patient years. During maintenance, we had 0.85 serious infections per 10 patient years, whereas in main Ritsan, which is another one that looked at both azathioprine and Rituxan, they had a very similar rate of serious infections in both arms, which is, we think, an exceptionally good rate in all cases. Back to this entity of late onset neutropenia. So 90% of the patients never had what we're calling late onset neutropenia, but the other 10% had episodes where their neutrophil count would suddenly drop. And I've plotted here the neutrophil counts on this group of patients that had the late onset neutropenia. And you'll see that each one of these lines represents a patient. And their neutrophil counts would tend to be normal most of the time, the overwhelming majority of the time, but then you'd get these sudden drops in neutrophil counts all the way down to 0 to 1 cell. So they have absolute neutropenia, some of them going to 0 neutrophils. With this neutropenia, they are susceptible to additional kinds of infection. A study out of Holland suggested that the majority of them bounce back without any intervention, and so you don't necessarily need to do too much. However, some of them get serious infections during these episodes, and so we've had there's many reports now, and we had a couple patients who came in with serious infections requiring antibiotics, intravenous antibiotics, associated with low neutrophils. If you find the neutrophils low, they respond almost instantly to a single dose of Neupogen or filgrastim. So it's very easy to treat. And so we took on a task of trying to monitor for this, and we monitored a lot of neutrophils and found almost no low neutrophils. And then still the patients would come in with a fever and a low neutrophil count. So our strategy to deal with this is that anybody on Rituxan who has a fever needs an immediate neutrophil count. And if it's low, we think they need Neupogen. And with that, we've had very few events of any kind of severity in terms of infection. So that's one strategy that we've been using to deal with that. But this entity of late onset neutropenia is a scary one when it happens. And overall, I think it's the biggest side effect of Rituximab. And I'm going to show you one step further. We had 2 patients where it went a little bit beyond just episodes of neutropenia. The first one, we stopped the Rituxan after 28 months, and they've still had 1, 2, 3, 4 more episodes of neutropenia, or 5 more, I guess, counting this one, 4 more. And their B cells have not recovered in 3 years. Okay, so this person's very upset about it because she doesn't know when her next episode will hit. She's been doing very well except for these 4 days when her neutrophil count dropped and she required additional treatment. This other one was even more dramatic. This is a woman who was treated for 3 years with continuous Rituximab, had several low episodes of neutrophil. Rituximab was stopped. She went a couple of years without any incident and then started having recurrent episodes of neutropenia that would respond to doses of Neupogen, and this became eventually at a very frantic pace, and she subsequently died of infection in the setting of episodes of neutropenia. So there are an occasional patient There is an occasional patient that has prolonged B-cell depletion after a few doses of rituximab. We don't have a good sense of that number because we're accumulating more data on that. The majority of patients recover their B cells in 6 to 12 months, but some of them have these long episodes of B cell depletion, and it makes us worry that they can have more patients like this. But we now have over 200 patients that have been followed for almost 5 years, and we have just these 2 patients that had this severe side effect, which we think is related to rituximab. And if you look at the survival rate as a whole from our population, if you take age, race, and sex-matched controls, this dotted line would be the expected survival rate, and our survival rate is on this Kaplan-Meier curve here, which is essentially identical. So for the first time, survival rate for maintenance after someone enters remission approaches the normal population with ANCA vasculitis. And rituximab was a huge part of this for 5 to 7 years, but what happens eventually? Is there any, if you have a 20-year-old, how long are you going to treat him with rituximab? We know that the rituximab is highly efficacious. We know the toxicity is low, but is there a rising rate of infection? Well, we've been unable to document a rising rate of infection based on serious infections, hospitalizations requiring IV antibiotics. But there's an increasing sense that some of these patients may be developing more smoldering infections, including bronchiectasis and chronic sinusitis being the 2. Of course, those are features that are associated with ANCA disease anyway, so it's a bit difficult to tell. So the rituximab may be useful for many antibody-mediated diseases. It's effective for maintenance. It's safe for at least several years, but what about the really long term? And more long-term studies are clearly needed to look at this. We're endeavoring to start a randomized trial where we take patients that have been on rituximab for 2 years and then randomize them to either 2 years or more, and when they're ready to come off rituximab, we randomize them either to rituximab redosing after B-cell return or rituximab redosing after ANCA return with the hope of avoiding clinical flares of disease. I should add that in another trial by Marianne Slot from Holland, they looked at how much kidney damage there was with each relapse. And they found that the eGFR dropped by about 10 mLs per minute with each relapse. So patients who have multiple relapsing disease, it's not a trivial problem. And in the long-term European trial, they had more patients progressing to end-stage renal disease in the group that was not treated with maintenance therapy. So relapses do kind of lead to chewing away at the kidney, and so we're very anxious to know what better long-term approaches can be taken with these patients. And so I'd like to stop right there and be happy to take any questions. Anybody have anything to ask? All right, well, thank you very much. Yes? Yeah, so CellCept has been tried, and there was one study I showed that compared CellCept to azathioprine for maintenance, and they had a 50% relapse rate on CellCept at 4 years. And that was with little bits of prednisone that were weaned off completely, I think, after 2 years. So CellCept by itself has not been very effective as a maintenance drug. And I have to point out that every trial, or every long-term study that looks at long-term follow-up of patients with C-ANCA and classic Wegener's shows that ultimately there's 70% relapse rates when you stop everything. And that, unfortunately, appears to be true with Rituxan as well. And so maintenance therapy becomes the big question mark for how to manage it for the long term.
What about cost?
What about cost? Well, I'm really hoping that the cost of rituximab comes down. Maintenance of 2 doses a year. Rituximab itself costs, I think, almost $8,000 a dose right now, and so 2 doses a year, that's $16,000 just for the drug. It's been pretty effective without a lot of other costs associated with it, but that's still a very expensive treatment protocol for a long-term therapy. There is competitive drugs that are coming out, biosimilars, and so I'm hoping that that changes the cost structure. The patent actually runs out, I believe, this year. Have I seen late onset neutropenia with what?
Induction only
with induction. Yes, and again, it can occur any time after the patient's on Rituxan, and we've had a few that have been within the first 6 months.
Is it more common for relapsers who have had Cytoxan before?
Is the late onset neutropenia more common for relapsers that have had Cytoxan before? And my impression is no, but that's one of the things we're actually extracting right now. Okay, well, thank you.